point today, we're going to actually show a video from Dr. Jonathan Bramson, who is our director, our Dean of Research at McMaster at some point too. But to keep ourselves back on schedule, we're going to start with our first speaker. And our first speaker today is Professor Nick Daneman, who is a clinician scientist at the Division of Infectious Diseases, Department of Medicine at Sunnybrook Health Sciences Center in the U of T. He also is a senior scientist at the Institute for Clinical and Evaluative Sciences and an infection prevention physician at Public Health Ontario. His research really focuses on this optimizing and prevention of healthcare-associated infections, particular interest in C. difficile as an infection, infections in critical care and surgical site infections, and antibiotic stewardship. And I need to acknowledge, as we start into Nick's talk, our sponsor today, and you're going to get a theme for the next few talks talking about this balance between the overuse of antibiotics, which in many parts of the world and even in North America has led to resistance to antimicrobials, and the balance of treating people with sepsis who need antimicrobials. And so with that, I will let Nick come up and tell the story a little bit, and maybe actually use the word balance in there. Nick, welcome.
Thanks so much, Allison, and for the honor of this invitation to speak at this inaugural Sepsis Canada in-person conference, and the opportunity to speak about two of my favorite clinical and research interests, sepsis and antimicrobial resistance, which each on their own are super, super challenging, but when you bring them together, seem like a very difficult challenge to overcome, as well as one potential solution to this, which is optimizing antibiotic treatment duration. So to do this, my logic of my talk will go like this. I'll start by showing how early adequate antibiotic treatment for sepsis saves lives. Then we'll look at antimicrobial resistance as a global public health threat, and that also causes worsening mortality in sepsis. And then speak about this one way of potentially balancing these risks, which would be to optimize antibiotic treatment duration. And so for that, we'll look at the problems with treating too short versus the problems for treating too long, a growing body of evidence supporting the efficacy of shorter duration treatment. And then I'll give a shout out to our own trial that being led by myself and my friend and colleague Rob Fowler that many of you probably know, called Balance. And then try to look to the future where we can maybe try to do something better than all of this and try to work on individualizing treatment durations. So early adequate treatment for sepsis saves lives. I know I'm preaching to the converted here, so I'll try to keep this part short. Just show a little bit of evidence to this effect. This is one landmark study out of Canada by Anand Kumar and colleagues across 14 North American ICUs, including 2,371 adult patients with sepsis. And they looked at, as a main predictor, how long did it take from the onset of hypotension to getting that first antibiotic adequate for their infecting organism on the outcome of survival to hospital discharge. And there's a very famous pair of figures here from that study, which gets shown in many presentations like this. You can just see on the left, the gray bars show this delay that can happen from the time of hypotension to antibiotic initiation, which can be really quite long in a lot of patients. And as that delay marches up, you can see in the black bars survival marching down. And even when you look at it with adjustments, you still see this trend towards increasing mortality with longer delays in antibiotic use, with an estimate of an increased 8% absolute mortality increase for every hour of antibiotic treatment delay. And the signal from Anand study is stronger than what's seen in most, but there's lots of other studies showing kind of a similar effect. This is just one of many systematic reviews. I particularly like this one by Mikhail Paul. It's a bit older now, 2010, but they looked for any prospective observational study which had looked at adult inpatients with sepsis, and then again the predictor of time to adequate treatment as defined by an antibiotic with in vitro activity against the bacteria causing the infection on the outcome of 30-day or hospital mortality. And so you can see Anand study is just one of many, many. Already at that time, there were about 50 studies on this topic meeting eligibility for the systematic review. And it's pretty heterogeneous. You can see the results are a bit variable, but you know, the net signal is towards harm with delayed treatment. Almost all the point estimates from these studies fall towards the side of, you know, survival being better with earlier adequate treatment. And many of them are kind of lower quality studies and don't even account for how severely ill the patient was at presentation. But in the 26 studies that did do that, you can see here still a very strong association between adequate treatment and survival. So an odds ratio for mortality of 1.6, which they found meant that for every 10 people treated with inadequate empiric treatment, there'd be one avoidable preventable death. So tons of other individual studies we could go into, but because I think everybody here doesn't need to be convinced of that, I'll spend a bit of time now talking about the other side of this challenge, which is antimicrobial resistance. Again, there'd be kind of infinite data to draw on. I'll pick one study in case people hadn't seen it yet, which I think is kind of the most comprehensive to date by the antimicrobial resistance collaborators. This is hundreds and hundreds and hundreds of researchers across the world pooling data from tons of different countries, millions and millions of bacterial isolates, and trying to estimate, using data from calendar year 2019, how much death is happening attributable to or associated with antimicrobial resistance. They included 23 pathogens, 88 different drug-bug combinations, like I said, lots of countries, and there was 471 million individual microbiology pieces of data. And they found already in 2019 that there were almost 5 million deaths associated each year with antimicrobial resistance worldwide, and about 1.27 million directly attributable to bacterial AMR, and this is only increasing with time. E. coli was the #1 pathogen associated with these antimicrobial resistance fatalities. And even though they had such tremendous data, so many isolates, such good data on the prevalence of resistance, such good data on what bacteria are causing each type of infection, where they admit in their calculations their estimates are weakest is that they have very little data comparing mortality from a resistant versus a susceptible, sensitive bacterial isolate, because most microbiology databases aren't linked to any clinical outcome data. So we tried to provide some evidence to help fill these gaps in Ontario. We decided to focus first, and we're going to do this very soon, or I guess imminently within the next month, we'll have some results looking at all bacteria. But we focused first on just E. coli, since it's the #1 most common pathogen. And we asked, to what extent is antimicrobial resistance already associated with increased odds of death in the context of Ontario, like a really well-resourced healthcare system where we have excellent hospitals, excellent intensive care, free antibiotics, and good access to broad-spectrum antimicrobials. This is a retrospective observational study at ICES, and we were able to harness all the administrative databases that are housed there for many, many years now, but also to finally take advantage of Ontario-wide laboratory information system from a database called OLIS, which has been imported into ICS, and we've been working on cleaning for the last number of years, because all of our microbiology labs across the province process so many specimens all the time, and they just sit untapped in these archives. So we're able to link these to administrative data, and that gave us 14,548 episodes of E. coli bloodstream infection in the province. And so first, a little piece of good news is that our resistance rates aren't terrible like they are in some places in the world. So you don't have to worry about the 4 different color bars. Those are just different methods we use to try to impute missing sensitivities. But the bars are all the same height because all those methods are fine. But if you look at certain resistances like carbapenems, our broad spectrum, very broadest spectrum common antimicrobial, or difficult to treat resistance, which is resistance to carbapenems and a couple of other classes of agents, we don't have that problem yet in Ontario. So that's the good news. I mean, that's inevitably going to come. But in the meantime, we do have pretty substantial resistance rates to the drugs we do commonly use. 10 to 15% resistance to third-generation cephalosporins like ceftriaxone, to beta-lactamase inhibitors like piperacillin and tazobactam, 30% resistance to fluoroquinolones like ciprofloxacin. And is this important? So this was the main result from the paper. We looked at E. coli that were resistant to each of these agents and compared it to the E. coli that were sensitive to each of these different agents on the outcome of mortality. And if you look in blue, which is just a crude model where we don't take into account any potential confounders, there's a huge association between resistance and mortality. That's a little bit unfair because there is confounding out there. People with resistant infections tend to be older, have more comorbidities, more healthcare exposure. But in ICS in Ontario, because we can link all these rich clinical administrative data sets, in the red adjusted model, we can account for dozens of comorbidities, age, all sorts of measures of healthcare utilization and other potential confounders. And even though that does attenuate some of the association, you still see a very strong association between resistance and mortality across these different antibiotic classes. Most are statistically significant, and the ones that are most notable are the drugs that we use commonly for empiric treatment, which makes sense. So you can see a 30% increased mortality if you happen to have an E. coli bloodstream infection that's resistant to ceftriaxone or piperacillin-tazobactam. So this is tricky, right? We know, like I showed, early adequate treatment for sepsis improves survival. But we have these rising AMR rates. That means that our broader spectrum empiric treatment that we typically thought was broad is no longer really broad, and we're going to need broader and broader empiric treatment empirically if we want to have a good likelihood of adequate coverage for our patients before we have their microbiology results available. But if we keep using broader and broader spectrum treatments, that's just more drug pressure, and we're going to get more AMR, higher resistance rates, lower likelihood of adequate coverage again, need newer, broader agents, and that cycle is just going to continue forever. So one thesis that I wanted to put across today was that one kind of low-hanging fruit to improve our way of balancing adequacy of sepsis and mortality, if we can't avoid that initial aggressive broad-spectrum antibiotic treatment, is to at least optimize antibiotic treatment durations, which we've not been doing a great job of over the many decades. So just kind of walk through that argument step by step. So thinking about the risk of treatment that is too short or too long if we want to try to balance this and get it right. So from the very beginning of having antibiotics available for treating infections, people worried that if you treat it for too short, the patient may fail treatment. They may get better, but then relapse again with the same infection after treatment. And you may select out resistance in that culprit pathogen so that it then becomes harder to treat. And even Alexander Fleming, discoverer of penicillin, in his Nobel Prize-winning lecture made this ominous statement along those lines. He said, "The time may come when penicillin can be bought by anyone in the shops. Then there's the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug, make them resistant." Here's a hypothetical illustration. Mr. X has a sore throat. He buys some penicillin and gives himself not enough to kill the streptococci, but enough to educate them to resist penicillin. He then infects his wife. Mrs. X gets pneumonia and is treated with penicillin. As the streptococci are now resistant to penicillin, the treatment fails. Mrs. X dies. Who is primarily responsible for Mrs. X's death? Why, Mr. X, whose negligent use of penicillin changed the nature of the microbe. Moral, if you use penicillin, use enough. So this was his warning. And that's kind of the way we've thought about antibiotics for many, many years. But as we're learning more about the microbiome and the way AMR works, we're realizing that that antibiotic is not just exposing the culprit pathogen to this selective pressure to become resistant. It's also exposing the trillions of bacteria that are part of our normal flora to selective pressure. And that longer antibiotic duration rather than shorter antibiotic duration is going to cause greater disruption of that microbiota, more selection of antibiotic-resistant flora, and it's those flora that are going to become the source of future infections that are harder to treat for that patient, and also transmissible to other patients, neighboring beds, elsewhere in the hospital, and in the community. It's hard to study that with antimicrobial resistance, although we are trying. Kind of the one pathogen that's easier to look at in this respect is C. difficile, and it's been very well shown, for example, in this study in New York, of 7,700 patients and 241 patients with C. difficile. The longer you give a patient antibiotics, the more you disrupt their flora, the higher their risk of getting C. difficile infection. You can see in the green box here, less than 4 days, you can still get C. difficile. But as you go to 4 to 7 days of antibiotics, 8 to 18 days, greater than 18 days, there's a real dramatic increased risk of C. difficile infection. Not just C. difficile and AMR, there's other harms to excessive treatment durations. Pranita Tamma and folks at Johns Hopkins looked at one tertiary care hospital and found that 20% of people on an antibiotic had an adverse event, and the longer they were treated, the higher that risk. As part of the preparatory work for the BALANCE study that I'll show you about, we looked at the costs of excessive treatment duration and found that if you could even shift half of the people getting longer treatment durations for bloodstream infection to shorter treatment durations, that would amount just from drug acquisition cost savings alone to $700 million less per year in North America and more than $1 billion less per year in Europe. So lots of potential harms of longer treatment, but we'd still accept those if longer treatment was more effective for serious infections than shorter duration treatment. But there is this growing body of evidence out there that shorter duration treatment is as effective as longer duration treatment for most infections where it's been studied. I'll talk about our China Sec, led off in that research program with a systematic review looking to see if there were already studies of short versus long treatment duration for bloodstream infection. We also looked at other common infections that result in bloodstream infection. And this is now quite old, but even then there were 24 trials that we found of nearly 7,700 patients randomized to either short duration treatment, which was 3 to 7 days depending on the study, versus long duration treatment, which was 7 to 21 days depending on the study. And in this meta-analysis, you can't even make out the diamond at the bottom because clinical cure was pretty indistinguishable in those getting shorter or longer duration treatment. And it hasn't stopped there. People keep asking this question in common syndromes. So in our systematic review, the data on pyelonephritis wasn't that clear, but right afterwards in Sweden, 250 women were randomized to 7 versus 14 days of ciprofloxacin for pyelonephritis. Many had E. coli in their blood, and clinical cure was the same, both short and long-term, with 7 or 14 days of treatment. Another great study a couple years later, looking at intra-abdominal sepsis in patients who had surgery for source control, and then were randomized to either just 4 days, short treatment after the surgery, or typical treatment, waiting for the systemic inflammatory response, plus a couple more days, which usually amounted to more than double that 4-day length, on the composite outcome of surgical site infection, intra-abdominal infection, and death, and found that these approaches were equivalent. In fact, the patients that got longer treatment, all did was delay the relapses that did occur. Pneumonia, there have been multiple trials in the last several years. Here's just one from JAMA Internal Medicine, 300 patients randomized to 5 versus longer duration treatment. And again, clinical success looks similar with long and short duration treatment. So the data is really piling up across multiple syndromes. Along with Rob Fowler, as I mentioned, we've been working hard on trying to provide this data for what we think is kind of the most severe of infections. I know this is a Sepsis Canada conference, and we could focus on sepsis. We tweak it a little bit and focus on bloodstream infection. The Venn diagram is very overlapping there. Bloodstream infection is a bit cleaner because you know who has it based on that blood culture result, whereas sepsis, some are culture negative, and it's harder to define what we mean by adequate treatment and length of treatment. But we asked, is shorter duration antibiotic treatment 7 days, non-inferior to longer duration treatment, 14 days, for patients with bacteremia? We started out only in ICU patients, but have expanded to hospital-wide approach. And this has really been like a decade in the making. I showed you the systematic review that we started with, then practice surveys in Canada, Australia, and New Zealand, Canadian Critical Care Trials Group multi-center observational study, a pilot in ICU, a pilot on the wards, and then finally culminating in our main trial, which I've been presenting updates over the years as we expanded to include 73 sites in 7 countries, mostly Canada, Australia, New Zealand, but a handful in Saudi Arabia, Israel, Switzerland, and the United States. And so what we've done is we essentially randomized people, and we've left it pragmatic, and the doctors can give whatever antibiotics they want, by whatever route, whatever frequency, but we just intervene on the date of stoppage, 7 versus 14 days. It's an open label study because there's so many different bacteria that cause bloodstream infection and so many different sources of those bacteria. But we mitigate selection bias a little bit by concealing which group the patient's in until day 7. And we're trying to be very broad here because we want to try to have a result that will be generalizable to almost all patients with severe bacterial infection. You're in a hospital and your blood culture is positive, just excluding people with neutropenia and transplant, but other immunocompromised is fine. Excluding people with a syndrome that needs long treatment, which is a very short list. Excluding people with a single positive blood culture with a contaminant that might not need antibiotics. and then Staph aureus in Canada, which may need longer treatment. And we're trying to show that 90-day mortality is non-inferior in both an intention to treat and per protocol analysis. We also want to have a whole lot of other clinical secondary outcomes, which we also hope will be non-inferior with shorter duration treatment. And on the right side, a whole bunch of secondary outcomes that we hope will be superior with shorter duration treatment, which is really the driver of why we want to do this. We want to show that these people can have more antibiotic-free days, less adverse events, less C. difficile, and importantly, less antimicrobial resistance. And so I've presented this many times as updates, so it's pretty exciting to say that we had our last enrolled patient finally on May 2nd. They hit 90-day follow-up on July 31st. I made these slides ahead of the talk a couple weeks ago, so I wrote analysis is underway. There's just 2 sites with a couple of patients left to enter, but analysis will be underway, we think, next week or the week after. And we hope we can disseminate the results soon. So if invited back, Rob or I could give those results. In the meantime, that's very blunt, right? We've put a ton of work into it, pretty proud of getting it done, but still in the end, it's a pretty simple question, 7 versus 14 days. It's very blunt. If we really want to, make our way through this tricky challenge between adequate treatment and AMR and getting just the right amount of antibiotics and not too much, we should be individualizing our treatment courses. So I think probably everyone has heard this at least once from your parents or your pharmacist or your physician. Many of us that have clinicians have probably said this as well. Finish your treatment course even if you're feeling better. But this dogma is kind of being turned on its head. This was a nice editorial in BMJ a few years ago where folks argued that even though most of our guidelines in the US, the UK, Australia, Canada talk about completing the course, this is probably wrong, because if we know that longer treatment duration is going to promote more resistance, why aren't we just treating until people are better and then stopping? And that's, every infection is unique. So why am I fixing a treatment duration when, there's different pathogens, different inoculums of infection, different levels of virulence, different hosts with different levels of systemic or local immunocompromise, different comorbidities, different treatments in terms of different antibiotics and also different source control procedures they might be undergoing. And even after that, there's different trajectories of response, people that you can see getting better much faster and others getting better slower. So maybe we could individualize along these lines. I will say the one saddest part of my specialty, well, we have many limitations, but one is that we have no tests of cure for most of the infections that we treat. This is a Sepsis Canada talk, so let's just take sepsis as an example. You have an inciting infection, it triggers a cytokine cascade, patient has inflammation, multi-organ failure. Even when you've killed the last bacteria that incited that whole problem, they're still going to have some of this organ failure. And so when do you stop antibiotics? Hard to know. So because of these challenges and because of this push to give individualized treatment, we conducted a survey last year with Kwad Bomponsuo, an infectious disease graduate from Calgary, asking Canadian, Australian, and New Zealand infectious disease doctors 5 common scenarios of infection and saying, do you treat with a fixed duration or an individualized treatment duration? We realized we had to give them 5 options if we want it to be mutually exclusive and comprehensive. So, are you fully fixed? Do you fix the minimum and give some people longer? Fix the maximum, give some people shorter? Fix a range and tweak within there? Or are you giving fully individualized treatment to these patients? And there's a different color here for each of these 5 syndromes. Skin and soft tissue infection in blue, pneumonia in purple, cholangitis, biliary tract infection in gray, kidney infection in yellow, and bloodstream infection in green. And you can see it does vary by syndrome. If you look to the far right, which is fully individualized treatment, even though there's this push to give individualized treatment, really only the small minority of patients or physicians are giving a fully individualized treatment approach. It's much more common that they're giving a fixed duration or giving a fixed minimum or a fixed range of durations. So it is a dream to individualize treatment, but we're not there yet clinically. I know there's going to be a lot of great talks this afternoon on biomarkers, so it would be great to have a test of cure. Procalcitonin, I think, is the closest to the bedside, this calcitonin precursor hormone, which distinguishes bacterial from non-bacterial infection. the largest study on this in sepsis, in the Parata study in France, randomized people to usual care versus an algorithm using procalcitonin to stop antibiotics. And they found that it worked in that there was no difference in survival, even though procalcitonin shortened the length of antibiotic treatment. But unfortunately, the diagnostic accuracy is not great. So a positive likelihood ratio of 3 and a negative likelihood ratio of 0.43, I wouldn't personally consider enough discrimination for my patients with sepsis. People don't necessarily adhere to the algorithm. Even in that study, half of the doctors didn't follow the result. And lastly, its real-world impact is questionable. In this study, in a large American database called Premier, in 20,000 patients in 107 hospitals, those that had procalcitonin measurements actually had longer antibiotic treatments and more C. difficile, which was sort of disappointing. So maybe we need a combined approach. We can keep doing studies like BALANCE to establish the general safety and efficacy of shorter treatment, and then use biomarkers and diagnostics research to identify patients that need longer treatment. Clinically, we're still kind of stuck for now. I think we can use the results of fixed duration trials to set our general approach to practice, and then reassess patients and change duration to individualize where we can, recognizing that not all bedside information is going to inform us. And I'll stop to summarize. So early adequate treatment improves survival in sepsis. Rising rates of AMR are associated with worsening mortality. One way to balance those two might be to optimize treatment duration. And we've used long treatment durations historically because of fear of selecting resistance to the culprit pathogens, but there's lots of harm of longer duration treatment. And growing evidence that short duration treatment is effective. Hopefully BALANCE will answer that for bacteremia. And I'll put /sepsis there. And it would be ideal if we could individualize treatment durations and really get to perfection there. But tests of cure are lacking for most infections that we treat. So as I said on the last two slides, best care is probably resetting our usual practice to shorter and then doing our best to find which patients need longer treatment. And tried to cover a lot of material in my half hour, so I've left my email there if people have any questions that they'd like to pass my way.
Nick, maybe we do have a moment for a couple of questions. Anybody got any questions for Dr. Daneman? I think as we move along through this, any questions from our patient partners who've experienced antibiotics more times than they like to count sometimes? No questions, Nick.
Yeah, from the patient perspective, like when we launched the trial, people had some concerns about shorter duration treatment, but by the time we're done, from the patient perspective, people are often, refusing longer duration treatment and not wanting to be randomized to more antibiotics.
My fear is that a lot of the doctors don't recognize sepsis right away, so they're worried about the time for the antibiotic time. I'm just wondering if that's another obstacle in actually diagnosing sepsis.
Worrying too much about
Antibiotics, like a lot of people didn't get the initial antibiotics.
Yeah, there are a number of studies out there trying to look at ways to improve time to adequate antibiotics, and there have been legislation in places with quality indicators measuring what % of your patients get antibiotics within a certain time window, like 4 hours for pneumonia or certain time windows for sepsis. Those do tend to be effective in getting more people on antibiotics earlier, but they also end up getting lots of people on antibiotics that don't need them. So it's a super tricky balance.
One more question and then we'll try to keep on schedule.
Thank you. That was a really amazing talk. I was just thinking methodologically why you chose to go for 7 days, because obviously, as you kind of alluded to with the personalized treatment, there's a lot of heterogeneity in terms of things like pharmacokinetics, pharmacodynamics, the physiology of the patient. So why 7 days specifically as kind of your threshold for short-term versus long-term?
Yeah, people joke that in infectious disease, like everything has to be a multiple of 7 days of the week or 5 fingers of the hand. And so it's pretty strange that we don't give people 8, 9, 10, 11 days. We based our choices on the preparatory work. The survey, which I didn't show you, asked, quite a few hundred clinicians, infectious disease and critical care what their usual practice was across a range of different bacteria and different underlying infectious syndromes. And at the time we did the survey, 14 days was the most common. 7 and 10 days were the only other two common options. We thought having a third arm for 10 days might be reasonable, but then there wouldn't be a lot of separation between the arms and it would be harder to establish a signal of difference. So we ended up with the 2 at the extreme. But I wonder if we do show that 7 days is not inferior, if someone's going to want to pick that up and then compare it to even shorter durations for some of these syndromes.
Yeah, that's exactly it. Like, I'm curious if the results don't show what we're hoping for. Maybe there's another threshold that might be more appropriate that might give you that result. So,
yeah.
Thank you.
No problem.
Dr. Garland, last question. Just wait for the mic.
Thanks. Hi, Nick. I'm going to show a slide later that indicates that we overestimate the number of people in ICUs who have infection. That up to 40%, that autopsy studies show that up to 40% of people who are treated with antibiotics in ICUs never had infection. So there was, I don't know, 20 years ago, an enthusiasm for deceleration. Do you have any data, more recent data, on whether that's used and how often that's used? So you start people because it's important to start early, but you don't stop thinking. You don't commit to a week or 14 days or 10 days. You keep asking the question, do we think this is infection? Do we think this is infection? If the answer is no, stop the antibiotics in 3 days. Is there, are any of these assessments that you showed us or others looked at the utility, the utilization of deceleration?
Yeah, de-escalation is become kind of a research interest of mine as well. So I didn't show it today, but as Balance finishes, instead of resting for a bit, we're already launching something called Balance Plus, which is going to be an adaptive platform trial asking the next questions in bloodstream infection. One of them is going to be de-escalation versus no de-escalation. It's a little bit different from what you're asking because these will all be people with documented infection because they're still going to need the positive blood culture at the end of the study. And then we're going to randomize them to staying on that same broad spectrum drug they were on to finish their course versus going to the narrowest spectrum drug to try to establish that theoretical benefit that we think is there, but no one has established in terms of maintaining survival but diminishing antimicrobial resistance. There are something like a dozen observational studies showing a survival benefit to de-escalation, but they're all biased because less sick patients get de-escalated. And one trial which actually showed a harm of de-escalation, so that's why we want to try to replicate that. But I think what you're getting at is that population where maybe they never had infection and randomize them to finishing their treatment course versus de-escalating, which I think would be another amazing study to do, and I don't think has been well done yet.
Thanks. Thank you. Thanks very much.
Can I ask one question, though? Is this different in the pediatric and neonatal population? Or is this just an adult study?
The topics, I think, overlap. The study we've done so far is only in adults. There's a PhD student working on balanced kids, but she's done the observational study and the survey, and they show things very similar to what we showed in ours, but it takes a long time to do those, so we haven't yet launched a trial in kids. Hope to one day.